you'll hear a few personal opinions in this class, but not a lot, okay? Because I think that everybody's got their own idea about what's right and what works best and that kind of stuff. But I think it's only fair to present what, in general, in the profession of psychiatry and psychopharmacology are the agreed upon treatment guidelines, okay? And so almost all the information I'm going to share with you is drawn from and the two places where you can get really good information in terms of practice guidelines are from the American Psychiatric Association and then also from the Texas Department of Mental Health. In Texas, they have lots of money because they have lots of oil. And so they have done some of the best research in areas of ADHD, schizophrenia, depression, bipolar disorder, and I believe PTSD. And so those are the two places to go. And by and large, the reason these are good is that the NIMH studies and the Texas Department of Mental Health studies are considered to be uninfluenced by drug company, contributions, you might say. Now, I want to say that the research that comes out, probably 90% of research in the journals on clinical psychopharmacology come from studies that are sponsored by drug companies. And it's absolutely clear that these studies are often biased. For instance, they will use two drugs, head-to-head comparisons, and their drug they'll use aggressive appropriate dosing. The other drug they'll use dosing that is lower than most people would consider to be therapeutic. Or the drug they're comparing to, they'll use higher doses and they have more dropouts because of side effects. I mean, is there something wrong with this picture? Now, this is not to say that's true every single time, but most of the people, the experts, are saying, take it with a grain of salt if it's a drug company sponsored study. And fortunately, there are a number now of these new, they call it evidence-based medicine, but these are empirically designed studies that are huge in scope. They look at thousands of patients, and they are done by NIMH and some other organizations. I want to also start off by reading a quote to you. And this is from a psychiatrist. And by the way, most of the studies I have are in the reference list in the back of that separate handout that you have. So this book is in there, I'm almost positive. His name is Dr. Frateroli. And he wrote, now he's a psychiatrist, and he wrote a book called Healing the Soul in the Decade of the Brain. And, excuse me, here's what he says. He's talking about the story of Hamlet, which I'm sure most people remember from high school English class. Hamlet's deep quest for truth, love, and moral integrity in a corrupt and dysfunctional family. What would have been his score on the Beck Depression rating scale? Okay. Does he have a chemical imbalance? That's how narrow-minded and superficial our current psychiatric thinking has become. But maybe you think that that's too harsh, too one-sided view. But for the large and growing number of psychiatrists whose practice is limited to 20-minute, once-a-month medication management visits, the picture certainly fits. This dehumanizing way of thinking about human suffering as simply a chemical or neurologic problem rather than an emotional problem reflects a crisis not only in psychiatry, but in our culture as a whole, because it isn't just psychiatrists that would be eager to put Hamlet on Prozac. Our whole society is looking for quick fixes, easy explanations to help us evade the anxiety of the human condition, the anxiety inherent in self-awareness and emotional suffering. Psychiatry caters to our fears of self-awareness by offering to medicate away our distress so that we don't have to feel it. And I don't have to tell anybody here, I know at least half of you, I know you, some of you I don't, but my heart is in psychology as a psychotherapist, and his points are well taken. I will tell you, this class is about medication treatment, okay? And I absolutely believe that when it's appropriately used with appropriately diagnosed people, some of these drugs can be absolutely life-saving. But under the best of conditions, they will get people to maybe second base. And there's a tremendous amount of what is not addressed by simply taking a pill. Roy Menninger years ago said they'll never invent a pill that will mend a broken heart or fill empty lives or teach people to love one another. And so I know I'm preaching to the choir, but I think that this is one reason that mental health therapists are in a good position to interface in this kind of medical treatment. Psychopharmacology. Why this class? One thing is, your managed care company is not authorized payment for an enema, so I've come to beat the crap out of you. Now, I want to explain this cartoon, and first off, I want to say that I used this cartoon for a few years, and I gave a talk up in Portland, Oregon, and this woman came up at the break, and she said, she was just flabbergasted, and she was offended, that I used foul language in my slides, and she said, I want my money back, and it's hard for me to imagine a psychotherapist that might be offended, but my goal in life is never to offend anybody, and that's probably why I look so tired all the time. But anyway, I want to apologize right now if I've offended anybody for using bad words like managed care. Okay, so okay, that's the joke part. The real part is this, and that is that my beef with managed care, and I think this is shared by many people, is not as much with the psychotherapy part of this. Managed care is beginning to loosen up somewhat. HMOs realizing somewhat about authorizing more visits and that sort of thing. I think largely not out of humane reasons, but because of financial reasons and because of parity legislation and so forth. But the big gripe I have is the enormous pressure that's put on primary care doctors and nurses to treat psychiatric disorders in primary care setting. Okay, now let me just show you something. These are a couple slides you don't have. Okay, or it may be late. I put them earlier in the presentation. Look at this: 85% of prescriptions written. This is for antidepressants and for anti-anxiety medications are written by primary care physicians. That's where a lot of this is happening, and the problem with this largely has nothing to do with the competency of primary care physicians. It has to do largely with the fact that they're seeing 30 or 35 patients a day, and they can't get them in for follow-up. There's this guy I know, is a physician in Roseville, primary care physician. He got this, now this was like a year and a half ago, but he got a letter from his managed care company. He's on a panel for this managed care insurance company, and they scolded him. They said basically, look, you're making too many referrals to psychiatrists and to psychotherapists, and knock it off because it's too expensive. And by the way, all of your colleagues are doing this. You can do it too, and if you don't do it, we're going to kick you off the panel. Now, this guy, this doctor, he's a healer, and he's feeling the pressure of not having enough time to do the right thing. And so this is a broken system, and it's going to get worse. Take a look at this: fewer MDs entering psychiatry. During the last 15 years, the number of medical students that choose psychiatry as a specialty has dropped by 50%. And there's probably one main reason for this. And first I should say psychiatry is about the lowest paying specialty in medicine, but the main reason is because they're getting squeezed out of being able to do psychotherapy. They're doing these 20-minute medication management visits, and they don't like it, and then they have to hassle about even getting paid for that. Two of my best friends are psychiatrists, and they're fed up. They understand the role of medication, but they also want to do psychotherapy, but they can't do it because people are going to, they're getting their therapy from lower priced practitioners, and these guys are becoming pill pushers in a sense. I don't mean to denigrate the work they do, but that's where things are heading. Now, the psychiatry, American Psychiatric Association, and numerous other psychiatry organizations across the country have been vehemently opposed to psychologists getting licensed to prescribe medications. And but there's one problem. Now here I'm very much editorializing, but that is, I'd like to get all these guys and gals together and say, okay, I got one question for you. How do we address this huge need that there are millions of mentally ill people that are not getting served? Now you tell me, how to address that need. And if this means, and they say, well, primary care, you know what their answer is? Primary care doctors can take care of the simple ones. We'll take care of the serious cases. Well, but the data shows that does not work. So whether it's nurse practitioners or psychologists, people that have adequate training, and absolutely, people have to have very rigorous postgraduate training to do this, okay? But if they can demonstrate that they have been able to successfully master the material, and like for psychologists, you have to treat 100 patients before you get licensed, okay, and being supervised by a physician. The Department of Defense, about almost 15 years ago now, started a program where they train psychologists to prescribe medications, and they did after 2 years of they're actually practicing. They reviewed outcomes in terms of successful outcomes, but also the presence of any kinds of problems that developed, where they made a mistake or something, and it was no different than you saw with psychiatrists. I mean, psychology respects data. And people can get into territorial kinds of scraps, and that sort of thing, and my theory is bigger than your theory and all that kind of stuff. My profession's better than yours. But I think what's at stake here is enormous suffering, especially from people that don't have very much money. Okay? Now, another slide here that you don't have, but I just threw in. 30% of people in primary care setting never fill the prescription, their first prescription. You know what happens? The doctor spends 15 minutes with them, and even if they do a very good job of talking about the medication, which I think is impossible to do in 15 minutes, but 30% of people walk out the door, they toss it in the trash can. And why? Because they are demoralized. They're pessimistic. A lot of these people are depressed, and they conclude, well, it might help somebody, it won't help me. And then it never gets asked about again, which is, insane. But this is the nature of mental illness, is that people, don't go to treatment for trivial reasons. They've tried everything they can to struggle to get on their feet, and they're collapsing. And so that's a problem right there. But we know this, okay? This is the nature of many types of psychiatric disorders. You can see that a fourth to a third of them stop their medications in the first 30 days. Well, there's good reasons, understandable reasons for this. One is a lot of these medications have huge side effect burden. Okay. Secondly is many of the medications, as everybody here knows, take many weeks to work. Okay. And people are already on the edge of just giving up on practically everything are going to give up on that. And then you can see the people that actually do continue to take the medications, 40% stop within 4 months, and most of them never tell their doctor. Okay, so I mean, there are a number of studies that says the same thing. What it says is it doesn't work in primary care. All right. So why take this class? Okay, the one reason, there's a couple of reasons. One reason is because we know our clients. We see them. We're in the best position to really notice if they're improving, if there's a failure to improve, if they in fact are going downhill, if they experience adverse reactions to the medications, if they have unexpressed worries and fears about medications. We take the time to find out, how do you really feel about this? And in 3 states now, psychologists are able to prescribe medications. That's probably going to continue, I hope. But between now and then, the name of the game is that psychotherapists need to become really experts at being able to collaborate with primary care physicians. Now, I know there are going to be some of you, but just also like some of our clients who don't want to have anything to do with medications. For whatever reason, people are anti-medications. And when we look at this stuff, I'm going to talk to you about what the drugs do and the benefits, but I'm going to really come on strong also about their limitations. Okay, but here's the deal, and that is the law and the ethics of our profession is that we have to provide informed consent. Informed consent can be very legalistic, okay, but more than that, it's just doing the right thing. Informed consent means several things, but mainly what it means is once you've made a diagnosis is to tell the person, this is what I think is going on. And here are the treatments that have been shown in research to be effective. And let's say that you are adamantly opposed to the use of antidepressant or what have you. Nothing wrong with that, okay? But it behooves you have to tell them that that is an option. And also, their options are over-the-counter antidepressants, and there's good evidence that they can work if you use them right, okay? You may also talk about, like for instance with depression, exercise is very effective in treating even severe depression. Now, the downside is it's nearly impossible to get somebody who's depressed to exercise, okay? But the research is there, okay? But this is about laying out, it's about being honest. It's about laying out options for people, discussing pros and cons, and basically giving them their right to make informed choices about their treatment, okay? And so, you know, that's what we have to do. Okay, and you might say, now in my personal opinion, I strongly prefer this behavioral approach. Like for treating OCD, look at the data. Behavioral approach for treating OCD, much more successful than medications. Okay, and you can say that with honesty. Okay, but still we need to let people know the facts about, you know, what the treatment options are. Okay, now the second thing is this about this class, and that is a lot of what we talk about this year, next year, is going to be somewhat different. It's like shooting at a moving target. It's the nature of this is that there are new discoveries that are made, new drugs, new technologies, new understanding. They sometimes find out drugs actually don't work very well. It's like shifting sands. And so what I really hope is that you'll glean some very specific, useful clinical information that will translate into your being in a better position to provide good treatment for the people you're seeing now, but also to be able to be a skeptic about new medications, to really get it about the limitations of medications and not just buy this hook, line, and sinker. The great tragedy of science is the slaying of a beautiful theory by an ugly fact. One of my favorite quotes. And so I'll be talking about some facts in this class, but most of the stuff here are theories, okay? And I've been around long enough to know that you know, some theories that people were very wedded to got shot down or revised considerably in the face of new data. Okay, the man who knew enough. Well, you know, you can't just stop here. I mean, if you're going to keep up with this, you need to stay on top of it.